we'll get started here in a minute. If anyone wants to adjust their screens, they can with the interpretation in the video, and then we'll have the Spanish channel available soon. All right, we're gonna get started in about 1 second. I think we've got everyone positioned where they need to be. Thank you again for joining us today. All right, welcome everyone. Thank you for joining us for our COVID-19 update today. We have some great speakers with us. Today we have Dr. Eric France, Chief Medical Officer for CDPHE, Kate McIntyre, Deputy Director, State Vaccine Task Force, Rachel Severson, Immunization Section Data Analyst. Oh, sorry, that's me. And Scott Sherman, Brigadier General. And we're actually going to start with Dr. France today.
Good morning, everybody. I'll just start with a review of our cases, and you'll see, of course, that our most recent numbers continue to stay flat and low. It's been now 3 months since we hit our peak in November, and we've seen this nice decline. Over the last 2 weeks, there's been more of a plateau now of cases and hospitalizations. And so happy to see that they are not going up. We had on Tuesday just under 1,200 cases on 35,000 tests with a positivity rate that was just over 3%. Next slide, please. And this just shows you how we are doing compared to other states and what our 7-day incidence per 100,000 is. We're running just at about 120 per 100,000 population. Note too, of course, that across the US, we're predominantly in good numbers, not a lot of, if any, red areas at this point. And our numbers have been flat. Other states have improved. So sometimes we move up to the list, not so much because we have a worsening outbreak, but because the rates are declining in other states. Next slide, please. The hospitalized number also continues to fall. It's at 376 as of yesterday. And of course, we're hopeful that that will continue to decline over the coming months. In particular, as we see our vaccination rates improve, we should find that people 65 and older who have a high rate of hospitalization and death will start to show us declines in those numbers. I think we're at a place in general when we look at these numbers where we're thinking about the variant COVID virus, and hoping that it will stay low in numbers in our state. There is work that have suggested that by March and April across the country, the variant will become the dominant strain of the virus. And so there could be a spring surge in September or, I'm sorry, in April, if that variant started to grow. We haven't seen that at this point. And our hope is that the good behaviors and practices of all of us to stay distance, wear masks, will keep that variant number low for our state. Next slide, please. Here you see how we compare to the US in general, and you see while the US has been declining a little later than we did, we have hit more of a slower decline and maybe even a plateau here for this period. Next slide. Of course, there's been a great side effect from all the work to control the pandemic, and that's been reduced rates of flu disease. Our numbers of hospitalizations have been very low, in the tens rather than in the thousands. I think last year we had 3,500 people hospitalized, and I think last count we were 20s or 30s for hospitalizations in Colorado. And it's been the great work to improve vaccination rate with the flu. We increased our flu vaccination rates by 13% this year. We've also done great work to stay distance, and of course that translates into reduced flu. And the real benefit of low flu rates is low volume of illness and disease in our clinics. And so both outpatient and hospitals are able to take care of people with COVID and not have to worry about also being overwhelmed by influenza illness. And so it's great success for the people of Colorado, and it's wonderful for our healthcare workers that they haven't had to deal with both COVID and influenza this winter season. Next slide, please. Some new, hopeful, exciting developments coming our way, and that is, of course, the addition of the Johnson & Johnson, the Janssen vaccine. Of course, that's being reviewed tomorrow by the advisory committee at the FDA, and I would expect that on Saturday we'll hear about the emergency use authorization happenings, and on Sunday and Monday of this weekend, it will be the Advisory Committee on Immunization Practice meeting, the ACIP. They'll be reviewing the Janssen vaccine and making recommendations on how it should be used. So the FDA is looking at the safety and the efficacy and making decisions about making it available. And then the ACIP helps us by letting us know who should be vaccinated. And so we may very well be getting vaccine early next week if it plays out like it did with Moderna and Pfizer vaccines. As you see in this graphic, this is a new vaccine too from the technology side of things. Our Moderna and Pfizer vaccines were these new messenger RNA, mRNA vaccines, where the mRNA is incorporated into the cell directly and then translated into the spike protein. The new Janssen vaccine is actually using a virus that is adenovirus known to cause colds in humans, but they take that virus and they remove the genetic information that allows it to grow or replicate. So it is considered a non-replicating viral vector. They then introduce the genetic material for the coronavirus spike protein. And so then this non-replicating virus is injected, enters the cells, and again, doesn't spread or grow, but then is essentially transporting the genetic material for the spike protein, which is then created and presented to the immune system. And the data shows it's very safe and very effective. So we look forward to seeing this vaccine coming to Colorado in the next week to 10 days. Next slide, please.
Okay, and now I think we'll go over to Kate to give us an update on distribution.
Good morning, everyone, and thank you. We have now administered over 1,320,517 cumulative doses across the state. That's for phases 1A, 1B1, and 1B2. We've only done this by working together with all of our providers. We have over 850 enrolled providers across the state. As of this morning, you'll see the new numbers for first and second dose on the slide there. 883,137 are first doses and 437,380 are second doses across the state. As of this morning as well, we know we've administered 372,896 first doses of the vaccine to our 70+ population. That gets us to 95% of our goal of 70% of our 70+ population by the end of this month. We won't have the ability to see all of the data regarding how many doses we've administered over the weekend until a few days into next week. It just takes our providers a little time to enter all of that data into our system. So we'll look forward to keeping you posted on our progress toward meeting our goal next week. We are going to continue vaccinating 70 and older across the state into the month of March, which is important to remember. We want to make sure we make continued progress toward vaccinating all of our over 550,000 people over 70 in the state who want to be vaccinated. We've also made good progress on our goal of vaccinating educators and staff and licensed childcare workers by the end of this month, and the 65 to 69-year-old population. So we really appreciate all the hard work everyone has done across the state to get us to this point. We've certainly got more work to go. Essential workers, as many of you know, will be included in the next phase, which is phase 1B3. The goal that we had set was to move into that phase in early March, and we do expect more information regarding how our supply might increase early next week. I've got some news to share a little bit later in my comments. And we, in terms of the exact time frame for 1B3, all of this information will really help us decide on that and announce that as soon as we can. So regarding the state vaccine task force, we are staying in tune with how national vaccine supply may increase in the coming weeks, including the existing and all of the types of vaccine that Dr. France just went over. We are proactively planning for various scenarios as the Johnson & Johnson vaccine comes online, as well as potential other ones. The federal government has just communicated to us that we should expect around 45,000 doses of the vaccine. But as Dr. France explained, there are still some steps to get through before we know exactly when those will be delivered. So we'll provide more information as we have that, as those steps get completed. The process, once we do have Johnson & Johnson vaccine delivered, will remain the same as with the other two vaccine products, Moderna and Pfizer, that we're currently administering right now. What will happen is that each week we'll receive an allocation, and then those doses will be delivered the following week to all of our providers to administer across the state. So our vaccination process and our timing of phases still is dependent on the supply that we have. But as that continues to increase, we'll be able to administer doses to a greater number of Coloradans and hopefully move through the phases more quickly. We are working, like I've said, collaboratively with the Department of Homeland Security Emergency Management, CDPHE. We're all working together with our providers across the state to ensure we have the appropriate mechanisms in place so that we can deliver doses very quickly, and we are prepared to handle more doses as they become available. Just a quick reminder that our call center continues to be very active. That number is 1-877-CO-VAX. That's VAXCO. And our staff is helping people understand how and where to get the vaccine and answering questions as they come in. That's all I have this morning, and you can move on to the next slide.
Wonderful, thank you. And Rachel Severson is going to take us through the new additions to the county level data on the dashboard.
Thanks, Heidi. Yeah, so we recently added an additional county level data section on our vaccine dashboard. And that section title at the top of the dashboard has beta in parentheses because we want to emphasize that this section will likely be expanded in the future. It's not in its final form as is. So I'll just walk through some of the main sections in that new page. So the first one is doses administered per 100,000 people and also straight counts of doses administered. I'll focus on rates per 100,000 because when we're comparing across counties, since that's adjusted by different county population, that makes it a little easier to compare across counties. So these are counts of doses administered, not necessarily people who have received vaccine. So if someone has received more than one dose, they would show up here twice for each dose that they've received. Counties are colored into 5 buckets in the map on the left based on the quintile of doses per 100,000 that they fall into. So it's not necessarily worst to best, it's the bottom fifth compared to the top fifth of how many doses have been administered. And those same counts are in the bar chart to the right in descending order. And next slide, please. So if you click on one of the counties in that map, below the map, there's the distribution of demographic information for people who have received at least one dose who live in that region. And we group together regions for smaller counties so that we're showing at least a total population of 100,000. And the percent of people who have received at least one dose is broken out by age group, sex, and race and ethnicity category. And also when you click on a county, that county's region or a single county, if it's a large county, is highlighted in the bar chart to the right as well. And next slide, please. So the other main count that we're showing per county is doses administered, both per 100,000 and, doses distributed per 100,000 and straight counts of doses distributed. So again, counties are colored from a scale of that light gray to dark green, and that's the lowest quintile to the highest. And on the next slide, below the map on that page, we're showing the difference between the percent of doses that have been distributed to each county and the percent of the state population that they make up. So this is comparing how many doses we've been able to allocate to each county based on our federal allocation compared to how many people live in that county. So bars here that are colored blue have been distributed in a number of doses that's very similar or a little bit more than how many people live in those counties. And bars that are colored pink have been distributed doses that are a little less compared to that population. But it's also important to note that even on the tail ends of this graph, it's still a relatively low percent. Adams has the highest at 5% and Arapahoe has the lowest at 6%. With this data also, sometimes doses are distributed to providers like large health systems, for example, UC Health and Adams, and they then redistribute doses to smaller providers who are in other counties. There's also often mass vaccination events where people who live in many counties are vaccinated. And that's all I had. Thank you.
Great, thank you. Now we'll go into the Q&A part. We will use the raise hand function for this. I know some of you haven't been able to get your raise hand to work, so we'll do the best we can to get you in the other ways. So for this, we'll use the raise hand function. When it's your turn, I will call on you, and if you could say your name and what outlet you're with. I'd also say if you have any questions outside of what we've chatted about today, if you don't mind sending those over to media_info@state.co.us, that'd be wonderful. And then so I can get through as many of you as possible, I'd love to, let's go ahead and take first questions in the first round. And then if you have some secondary follow up, we'll go ahead and take those in the second round if we can get to it. So with that, I'm going to go ahead and start with Seth.
Hey, thanks. This is Seth at the Gazette in Denver and Colorado Springs. On the variants, I have a couple questions, but I'll stick with one to start off. Does the state still feel we're sequencing an adequate number of samples to really have a good handle on variant presence in Colorado? Thanks.
Hi, Seth. We are looking at a surveillance program in place now where I think we're doing 200 samples a week. We're looking at other opportunities. One of our contracted labs, Mako, will begin providing us data that will also help us in our surveillance for the variant. So it's expanding in terms of our surveillance. We think having more information from this other partner will be helpful for us as well. And in part, that's because the numbers are currently pretty small when it comes to the number of samples that actually are positive for the B117 UK variant. They're 1 to 3%, and when they're that small, they jump up and down a lot. And so, if we can expand our numbers a bit through this data from Mako, that might make the numbers a little more stable, even at those low rates, and we'll be able to see if the numbers are increasing even at those low numbers.
Great, thank you. Chris, let's go to you.
Chris Vandermeed with 9 News. I'm wondering if this question is probably directed to Eric. Do we have any idea why we seem to be plateauing right now in terms of cases and hospitalizations? The rate of decline certainly isn't going down very quickly. Do we expect this plateau to sort of remain in place? And in some counties are actually creeping up right now. Do we have a better idea as to why the plateau right now is so high and why the cases are starting to creep up in some areas?
I don't think we do. If you look back at the 3 months, we certainly made some big moves back in October, November that we think could be explaining the declines. And then, of course, we started opening up businesses to a degree, and the declines continued. And this is being seen, of course, across the country. And I think one interesting idea is that when we talk about herd immunity, it's been said that maybe there are multiple herds. So one herd is mostly staying home, working from home, staying safe, and their actual rates of disease might be quite low. Another herd might be those who are working in essential jobs, healthcare folks, people who still go to restaurants or socialize. And maybe amongst that herd, the number of infections is higher. And so there is a certain degree of protection that's happening amongst those who tend to go out. And if you think about multiple herds, that might help explain why it might be that we're staying low and flattening and we're not seeing this increase like we did earlier last year when things started opening up again. In the meantime, while we watch this every day and see where cases are, we're going to be working super hard, of course, to get everybody vaccinated and ask everybody to continue with those behaviors we know reduce the spread.
Great, thank you. And Natalia, we'll go to you.
Hi there, Natalia Navarro with CPR News. I'm wondering if you have any more information on if there's a date yet for when the state will be able to expand the pool of those eligible for shots.
Well, as you know, we've got these different priority phases that we're working through. And we've said in the past that we estimated moving to the 1B3 frontline workers sometime in early March, maybe the 5th of March. When we'll do that will depend, I think, with the vaccine supply coming in, as well as how far along we are with 1B2 groups and above. So we're working through that, but we still expect it to be sometime early this next month.
Great, thank you. Gabrielle, I'm going to go to you.
Thank you. This is Gabrielle from Fox 31. I do have two questions, but I'll start with this first quick one. As far as the variants of concern and the variants under investigation in the state, are they still mostly made up of the B.1.1.7 variant from the UK and the variant from California, or are there other variant cases in the mix now too?
That's correct. It's those two that are the predominant ones.
Great, thank you. Allie, I'm gonna go over to you.
I think she had a second question though, real quick.
Oh, I'm sorry, go ahead.
Yeah.
Awesome, thank you, Dr. France, I appreciate it. Also, my second question was just, does the state have any plans to increase services to vaccinate homebound Coloradans?
Yeah, we are. We're actually contracting with some terms that are going to be focused on homebound, especially at age 65 and above, that to get them vaccinated.
Is there an ETA on that?
No, it'll probably be, it's in within the next couple of weeks. We're just finalizing the contracts.
Got it. All right, thank you.
All right, Allie, let's go over to you.
Hi, yeah, thank you. Allie Levine with 9 News here. You mentioned you are planning for various scenarios with the arrival of the Johnson & Johnson vaccine. What are the conversations like right now around distribution? And how will you decide who will administer J&J and who will administer Pfizer or Moderna? And then just kind of a bit of a follow-up on that, on that note, are you concerned people are going to choose not to get a vaccine if they're offered the J&J because of that 66.1% number being lower than what's touted by Pfizer and Moderna?
Well, I guess an answer, a little part of it. We're waiting on the ACIP guidance that'll come out on what the federal government recommends that people be vaccinated with it, age group or whatever the guidance is that'll come out. We plan to distribute the same way we do with Pfizer and Moderna vaccine to the providers, and we'll go from there.
Great, thank you. Lucy, let's go over to you.
Hi, Lucy Haggard from the Colorado Sun. I wanted to check in how much percentage-wise of the state population needs to be getting a vaccine for it to be effective? And are you worried that there are a lot of people that are going to turn down a vaccine still?
So it sounds like you were asking maybe about a question on herd immunity and what percent of the general population should be vaccinated so that we're all protected, even those who haven't been vaccinated. And nationally, the recommendation has been that we should be at least 70% of the population vaccinated. And I think if we keep up with our current pace, we should be there. And in some ways, we have maybe a flag in the sand of Labor Day. Like, can we get there before schools open this next year? And there's just so many variables when it comes to the supply itself that maybe we'll actually be there by July. Maybe things will be going faster or maybe a little slower. So it's hard to really predict just where that will be. So far, we've been in maybe the good space. If you think of the whole of everybody who wants vaccines, there's a whole lot of people who want to be vaccinated, right? And so that's what we're dealing with, is the day-to-day high demand for it. And there may be a time towards the end of all this effort where we get to a place where now we have to work at encouraging people to be vaccinated because they're not really interested, but we'd like to see them choose to be vaccinated. So the strategy at that end period may have to change to one of communications marketing and poster work to get groups to be vaccinated. But at this point, and probably for the next 3-4 months, it's really just getting vaccines out because there's all those people who want to get it.
Great, thank you. And then Vinny, I know you couldn't get the raise hand to work, so I'm going to go ahead and go over to you.
Thank you very much. Good morning. This is Vinny Belch, Shoelace of Bloomberg News in Denver. Dr. France, You said you're still awaiting final guidance from the federal government regarding the Johnson & Johnson shot. At this time, does Colorado at least have any preliminary plans on deploying the J&J shot? I guess you said you're anticipating 45,000 initial doses. And will the J&J vaccine, as far as you can tell right now, be used to target specific populations? Thank you very much.
Yeah, thank you for the question. Really, my desire is to wait until Monday and not think we're going to do one thing to hear that the recommendations might be otherwise. So I'm certainly waiting for the ACIP recommendations on Sunday and Monday to clarify that. You can imagine we might think of them, at least though, from an operational perspective, that, well, if you're doing a large event somewhere and the population is one where just getting one shot through, it works better, that might make sense as a place for the convenience of just a one dose option. In general too, I call out that as I think about vaccines, there's really probably two end goals: preventing deaths and severe disease, hospitalizations, and pushing to herd immunity. And it's clear that the J&J vaccine does a very good job at preventing severe disease. And while its efficacy is lower, it will still be an important tool for our overall strategy to hit herd immunity. So we can look at that number of 66%, 72% for US citizens in terms of the efficacy and say that sounds lower. Is that not as good? But I'm instead looking at the number of severe disease cases that were prevented, over 85%, no deaths from COVID among the people who were vaccinated versus a number of deaths in the placebo group, and seeing its great success in that regard.
Great, thank you. And then Meg, I think you also had some trouble with your raised hand, so let's go to you.
Thank you. I wanted to ask about with the variants, do we have to monitor those signs of trouble with that differently? Because I believe some countries in Europe locked down quite a bit earlier, even when they didn't have cases, in anticipation that this thing would spread much faster, and potentially they would need to react faster to head off the problem. Do you see any need to do that?
That's a good question. We work closely, as you know, with the School of Public Health, and they have been providing us with some models that look at potential variant spread and what would that look like during the time that we're also ramping up vaccines. And I think one of the key takeaways from their models is that we might expect the variant numbers to be coming up in a significant way in the second half of March and into April. And so if the variant is spreading now, the cases are so rare, I think it's estimated 1 in every 200 Coloradans has COVID in general, and then only a small percent of those are the variant. That variant spread is very few in number and isn't really visible. However, if it's spreading and spreading, by the second half of March and into April, the numbers may start going up. And then our actions may be similar to our non-pharmaceutical interventions in the past of mask wearing, having people stay home, avoid gatherings, and will be based on the decisions of the speed that it's going up and the degree of vaccination in the population, and new science that we might develop between now and early April.
Great, thank you. And before we start going into second questions, I believe, John Engel, I think this is your first.
Yeah, thanks. It's John Ingold from the Colorado Sun. Thank you for taking my question. I have two quick ones. First is, have you seen an issue so far with people not showing up for their second shot for the Pfizer or Moderna vaccines? What are the numbers on that? And then second is that in the demographic data for the vaccinations, it always looks like women are making up a bigger chunk of those who are being vaccinated, like around 60%. And I'm wondering, is that a function of the populations that are eligible for vaccination so far, or is that something where you're seeing higher hesitancy among men?
Maybe I'll start with the second one, and then maybe B.G. Sherman could answer that first question. It's hard to know just yet why the gender differential is in place. It's clear that when you start with healthcare workers and people over 70, those are both professional field and an age range where there are more women than men. So you would naturally expect that there will be more women than men vaccinated based on a longer life expectancy for women and the fact that many people who work in healthcare and residential care are women. Are there also some underlying differential hesitancy by gender? It's possible, but it would probably even there be masked by just that big difference in who we vaccinated to date and the fact that there's going to be more women in those groups.
Yeah, you're right on, Dr. France. Between healthcare workers and over 70 and with teachers, you have a lot more women in those categories. So that's why we're seeing so much more women. For your hesitancy question, for the older population and the healthcare workers, there's been very little hesitancy on, we still have thousands on wait lists. And that's really our goal, is to really break down those wait lists and get those people, and they're our most vulnerable population, of getting them vaccinated. And there'll be more information on that next week as we look at later phases. But you'll see also, we're 2 to 1 between first dose and second dose. And that's right on track with the 3 and 4 week wait period between Pfizer and Moderna. So that's exactly on track where we're supposed to be. So, you see there's very little hesitancy in the groups that we've had now. We're seeing more hesitancy in teachers. I can't give you that exact data, but that's what we're hearing from superintendents and at the county LPHA level, that there's more hesitancy in teachers, but we're also talking about a younger population. But that's where we're seeing it. And certainly we'll have more data on hesitancy as we get into later phases.
Great, thank you. And it looks like we have time for one more. So I'm going to go in order. It looks like we have Seth. Let's go to you.
Thanks. A couple of follow-ups again on variants. First, Dr. France, can you kind of expand on what you mean when you say Mako is going to give you more data? Can you kind of talk a bit more about that? And second, there's been reporting that Moderna is going to offer sort of a booster shot for the South African variant. Is that anything Colorado should be thinking about, or was that in our future at all? Thank you.
Thanks, Seth. You may be aware that the PCR tests that look for genetic material for the viruses are many. There are different tests that exist, and some of them look for this thing called the S drop, which is with the variant. When the variant is tested, it doesn't light up for a piece of the genetic material that's for the S gene area. And so in the panel of results, you'll see what's called an S drop. And then if you see the S drop, then you can take the sample and do the whole genome sequencing to determine if it's B117. Not all the PCR testing companies use the S gene area as part of their PCR test. Mako does. And so Mako and the state lab does as well. So Mako and the state lab now can both find S drops. And And when you find the S drop, you can then do more assessment to see if it's actually the B117 variant. But with another company, they don't use the S gene, there isn't an S drop, and so we're not using them as part of that effort in surveillance. And then regarding the South African variant and Moderna's announcement of developing a new booster, I don't think we should do anything here in the state, but just pay attention to that. It's maybe at the earliest the fall, but probably next year, and only if the South African variant becomes the world variant and clearly failure of the current vaccines are needing to be changed. So much more that needs to happen and show over time before we'll know whether Colorado needs to be worried or concerned about that.
Thank you.
Great, thank you. And if we didn't get to your question or your follow-up, you can send that over to media_info@state.co.us, and we'll work on that for you. And with that, I want to thank Dr. Eric France, Chief Medical Officer, CDPHE, Kate McIntyre, Deputy Director, State Vaccine Task Force, Rachel Severson, Immunization Section Data Analyst, and Scott Sherman, Brigadier General, for joining us today, as well as both of our interpreters. And I hope you guys have a great rest of your afternoon.